We literally have today, Tuesday, and Thursday. That's all we got left. We can do this. Just gotta push through. If I can do this, you can do this, because trust me, I want to be done as bad as everybody else does. All right, so we finished on Tuesday looking at the anatomy of the nephron. Yes, and we drew the picture and we labeled all the parts. We're going to go through the blood supply real quick. You need to know the order of these arteries, what becomes what, and we're going to go all the way through this process. This is more than one slide of blood supply. Okay, so we start with the abdominal aorta, and the abdominal. Oh, and I'm going to point something out here. I'm going to go ahead and change it now. We're going to call the interlobular arteries, we're going to actually call the cortical radiate arteries. It will make things less confusing. Okay, so make that change on your PowerPoint. And then I'm going to zoom us in, and we're going to sort of follow this path through. Okay. All right. So we start with the abdominal aorta. The abdominal aorta brings blood in through the, I need a good color for this. In through the renal artery. And the renal artery will then split off into segmental arteries. All right. They're not labeled on there, but that's what they are. The segmental arteries will go to the different segments of the kidney. Okay. You'll notice that each segmental artery runs and then branches to move up in that cortical column, right? So the segmental artery is going to branch when it gets up here into what we are going to call the interlobar arteries. Okay, interlobar, between the lobes. Okay. The interlobar arteries will then work their way up and form the arcuate arteries. Okay. The arcuate arteries are going to arc around that corner. Okay. And those arcuate arteries are going to branch. I'm going to switch over to a green color here because it's easier to see that way. The arcuate arteries are going to branch off into the cortical radiate arteries. Okay. They're in the cortex. They're like little rays of the sun. They radiate out into the cortex. Okay. So you've got the interlobar arteries that are between the lobes. You've got the arcuate arteries that arc around the pyramid. You've got the cortical radiate arteries that radiate out into the cortex. Okay. Each of the branches that come off of the cortical radiate artery become afferent arterioles for the glomerulus. So each of these points, every place where you see a little branch, there is a glomerulus attached to this. There's a lot of them in there. There's a lot of them in there. 25,000 or some ridiculous number. Okay. So the afferent arteriole, I'm going to step forward to the next slide so we can see this. I'm going to kind of back us up a little bit and sort of bring us in from the beginning. So this is our arcuate artery here, right? This is our arcuate artery that's running around the top of that, that pyramid. You've got the cortical radiate artery branching off of there. And then you've got the afferent arteriole coming into the glomerular capillaries. From the glomerular capillaries, we are going to exit out through the efferent arteriole. Now, I want to take a break here for a second, and I want you to think about what I just said. I have an afferent arteriole entering or bringing blood into a capillary bed. The blood that leaves that capillary bed leaves through an efferent arteriole. Why is that weird? Usually on the other side of the capillary bed, I have a venule. So I haven't gotten back to the venous system yet. Okay. Now, as we follow that efferent arteriole out, we are going to enter another capillary bed. We're going to call these the peritubular capillaries. And you see how they're kind of wrapped around, almost meshed around the tubules? Okay. There is in the juxtaglomerular, wrong word. Juxtamedullary nephrons. In the juxtamedullary nephrons, right, the ones that go way down into the medulla, there is a portion of those peritubular capillaries that we call the vasa recta. Okay, so this is important to note. All nephrons have peritubular capillaries. Only juxtamedullary nephrons have vasa recta. Do I need to say that again? All capillaries have all nephrons have peritubular capillaries. All of them. Juxtamedullary, the cortical nephrons, they all have peritubular capillaries. Only the juxtamedullary capillaries, nephrons, God, my brain, have vasa recta. Okay, so you remember we've got, I'm gonna go back here a second to help with this. So you remember we've got these two different kinds of nephrons. Yes, we have our juxtamedullary nephrons and we have our cortical nephrons, right? The cortical nephrons and the juxtamedullary nephrons all have blood supply wrapped around up in here. Okay. Only the juxtamedullary nephrons have vasa recta that come all the way down. Okay. This is one of those form causes function situations. Okay. The juxtamedullary nephrons do things that the cortical nephrons don't do. And therefore they need blood supply, that vasa recta in that medullary area. All right. So go back. So we've got our blood supply, and some of that blood supply that came out of that efferent arteriole is going to travel all the way down through the vasa recta, and then it will work its way back up through the venous side, where it will enter into the cortical radiate vein. Okay. The blood that doesn't go to the vasa recta, the blood that's just in the peritubular capillaries, will also enter in to that cortical radiate vein. Okay. The difference is how far the blood travels. Now, what did I just make by going from afferent arterial to efferent arterial, well, afferent arterial to capillary bed to efferent arterial to capillary bed to venial. What did I make? A portal system. It's a portal system. Remember, portal systems are capillary beds that are connected directly to one another without going through the heart in between. Okay? So we have the glomerular capillary bed, and then we have the paratubular capillaries that are connected by that efferent arterial. Okay? And we have to get through both capillary beds before we get back to the venous system, because we need what's in that blood, and we need to put some things back in that blood, okay, before it goes back to the heart. Because once it leaves the paratubular capillaries and the vasa recta, it goes through the cortical radiate vein into the arcuate vein, and then we're just going to go backwards, okay? So we've got our cortical radiate vein that goes into our arcuate vein that comes down to our interlobar vein. Yes. Yes. They all have the same name. It's going in and then turning around and coming out in the opposite direction. Okay? They're all named the same. So we're going to work our way back out through our segmental veins into our renal vein, and the renal vein is going to take the blood to the inferior vena cava, which is going to send it up to the heart. Okay? So this is just sort of a little side quest that your blood goes on, right? Video gamers know what I'm talking about, right? It's a little side quest. Blood's cruising along, and it's like, oh, let's go see what's happening in the kidney. 25% of your blood is going to run through there, approximately, per beat. Okay? So you need to know what becomes what and what becomes what, and so on and so forth. Okay? Questions? Okay. All right. Internal urinary sphincters. Males have a complete internal urinary sphincter. Its job is to prevent semen from getting into the urinary bladder during ejaculation. Okay? It is a multifunctional tube. And just like the multifunctional tube we talked about that shares both respiratory and digestive system, you've got to have structures to keep things from going the wrong way. In the male urinary system, there is an internal urinary sphincter that will close off the bladder during ejaculation to prevent semen from entering the bladder. That would create one really unpleasant bladder infection. Women do not have a complete internal urinary sphincter. We have an incomplete internal urinary sphincter, which means that we don't have as much protection in terms of the movement of urine out of the body. It's why women tend to suffer from stress incontinence more frequently than men. So particularly after women have had babies, or when they're lifting really, really heavy objects, stress incontinence is a thing. It means that you cannot control your bladder, and your bladder will void if necessary. That's the internal. Everybody has an external, right? Everybody has an external urinary sphincter. That is the one that you control, right? When you go to the doctor and you have to give a urine sample, and they're like, you know, here are the instructions for cleaning yourself, and then you want to start, and then you want to stop and insert the cup and then start again. That's the sphincter that you control. Okay. The male urethra is significantly longer than the female. The male urethra has to go from the urinary bladder through the prostate and then through the penis and out of the body. It's a much longer structure. Okay. The female urethra is very short. Okay. The female bladder sort of sits on the bottom of the pelvic cavity. And I can't draw it very well, but if you guys, so imagine in your head a wine glass, right? If you imagine in your head a wine glass with a stem, okay? The male urinary system is structured in a way that is similar to the idea of holding that wine glass by the stem, so that your hand would then represent the prostate. So the bladder sits there, and then the prostate, and then the rest of the tube. The female urinary system is more like if you hold your fingers underneath of the bowl of the cup, and the cup is actually sitting in the palm of your hand, that is basically your bladder sitting on the floor of the pelvic cavity. Okay, so structurally they're very different. I'm going to mention this here because it's a good place to mention this. And I've told you guys, right? 2 ureters, 1 urethra. Yes, ma'am. Yes. That is why women are much more susceptible to urinary infections and bladder infections, because there's a much shorter distance for bacteria to travel. And there are multiple openings in a very small space, right? At which point, this is the point where I'm going to say something, and I'm going to say this, and y'all are going to laugh. You're going to think this is the funniest thing I have said all semester long, but I am telling you that if you are going into a medical field, particularly if you are going into a nursing field, you will have a patient who will be surprised at this information. Women do not pee out of their vagina. There are a number of people in this world who do not know that. And you think it's ridiculous, right? It seems silly, right? You're like, how could you possibly not know that about your own body? We are all sitting here in a very privileged spot in terms of education. And not everybody in this world and not everybody in this country has access to the same level of education. And when you think about some parts of this country, for instance, in Appalachia, where there's very little access to education, and it is a very sort of conservative, the body is taboo, we don't talk about these things, we don't look at these things, we don't think about these things. There is no education on this. And so you are likely to encounter patients who do not know information about their own body that you think is common. And so I encourage you, as you work through your nursing program or your medical program, whatever program you're working through, think about finding a way to respond to those questions with compassion rather than by laughing, right? Because there's a reason those people don't know that information, right? All you have to do is go on the internet to see that there are people in this country, in this world, who do not understand how their bodies work. And that is a lack of education. So it's important, right? I go through this every semester. You guys did good. You didn't laugh as much as my other class did. Usually I get just ridiculous amounts of laughter in the room. So good for you. I'm proud of you. Excellent job. Okay. So we have the ureters. They're going to take the urine from the renal pelvis to the urinary bladder. Okay. The urinary bladder is literally just a storage vessel. It does nothing except hold the urine. Okay. There is a portion of the wall called a detrusor muscle. We're going to talk about that in a minute. And then there is a region within the bladder. It is a triangular shaped region called the trigon. That is the space between where the ureters enter the bladder and where the urethra exits the bladder. That triangular space is less stretchy than the rest of the bladder. Okay. And the reason for that is because we need those openings to stay relatively stable, right? We don't want those openings shifting or moving. When the bladder starts to fill, that stretching of the urinary bladder is actually going to compress the openings where the ureters enter the bladder in order to prevent backflow, right? As the bladder starts to fill, there's the potential that we could get backflow. And so we're going to compress those openings down so that there is no potential for backflow. What else? I don't care if you know about the different tissue types. I'm not going to ask you that. Okay, hydrostatic pressure. We're gonna go back to this. I know this is everybody's favorite word. What is hydrostatic pressure? The pressure of, well, fluid, right? So fluid in general being exerted on the wall, right? You guys remember this? Does this sound familiar? Hydrostatic pressure. Remember we had hydrostatic pressure in the capillary and we have hydrostatic pressure outside of the capillary. What's the other kind of pressure? Osmotic pressure is the other kind of pressure, right? And osmotic pressure is based on what? Molecules, the solutes, the things that are dissolved in the fluid, right? We're going to talk about those in more detail in a minute. So hydrostatic pressure, the pressure of the fluid inside of the ureter, is what is going to move the urine through the nephron, right? It's that constant inflow of fluid from behind that keeps that fluid moving through that nephron. When the fluid gets to the ureter, then we start using peristalsis. You get those peristaltic contractions through the ureter that will help move the urine from the nephron to the bladder. Why don't we just use gravity? Because what if you're upside down? What if you're laying down, right? You don't want backflow. We don't want to rely on gravity to move urine. It's got to be moved through hydrostatic pressure and through peristaltic waves. Okay? Yes.
Does gravity have an effect on?
I mean, gravity has an effect on everything, right? But yeah, but it's one of those things, right? Gravity will have an effect on everything, but when you're using muscle contraction and you're using peristaltic contraction, which is always going to be from behind, that will counter the effect of gravity if you are doing, what is that, aerial yoga or whatever it is that they do where they hang upside down by the little thingies, right? Pole fitness, those sorts of things, right? When you're hanging upside down, trapeze artists, right? They spend a lot of time upside down. Right.
You're on one of those like carnival rides that drops you.
Mm-hmm. Well, it will have an effect, yes. Yes, that will have an effect. It's going to cause more stretch in the bladder than anything. So peristalsis increases when the parasympathetic system is involved. If the parasympathetic nervous system is turned on, peristalsis increases. If peristalsis increases, what does that do to the speed of the filling of your bladder? It increases, yes. I have more frequent peristalsis, because it's usually once every few seconds to once every 2 to 3 minutes. Okay, that's the range of time that these peristaltic contractions can happen. Okay, the more frequent they are, the faster your bladder fills, the more frequently you have to pee. Sympathetic stimulation will decrease the frequency. Right? When you're running from a bear, you don't want to have to think about stopping to pee. Or at least I don't. Okay? The way that the ureters come into the bladder, this is important to understand, they come in at an oblique angle. Okay? They come in obliquely. That allows for that compression of the opening when the bladder starts to fill. Does all this make sense? Does anybody have any questions? No? Okay. All right. When you feel the urge to pee, when you feel the urge to urinate, that is called the micturition reflex, which is not a fun word to say. It's hard to get out. So as I said, the urinary bladder is just a reservoir. It's just a holding space. It can stretch to hold up to about 1 liter of fluid. Okay. The micturition reflex gets activated or turned on when the urinary bladder stretches as it starts to fill. The stretch receptors in the walls detect that stretch. They send a signal to the brain. The brain sends parasympathetic action potentials that cause the detrusor muscle to contract. The detrusor muscle contracting is what is going to start to move that urine out of the bladder and into the urethral space. At the same time, you have to have a decrease in somatic motor nervous signals to allow the external urethral sphincter to relax in order for the urine to be voided from the body. Right? You should understand that. Does that make sense? Yes? Good. All right. Moving on. Urinary 2. I'll give you guys a second to catch up.
How often does it happen?
Very rarely. It's very rare. The body will the body will force the external urinary sphincter to relax, and you will pee on yourself before your body will allow you to rupture your bladder. Yeah.
So why would kids visit?
So the issue is not that they have to learn how to urinate. It's that they go from, so when a baby is born, there is no, they just do what they do, right? So it's a training to understand when I need to go and how to control it until I get there, right? The body wants to void urine. You have the ability to hold that urine, right? If you have to pee and you're sitting in class and you're like, oh, we've got 5 more minutes left, I'm just going to wait. You have the ability to control that, right? Babies have to learn that control. Yeah.
Can urine ever get stuck in your like?
If you have crystals of sorts in the bladder, yes.
Like when you're done peeing and it's not comes out, there's never a time where you're not peeing, urine in it.
Well, so the urine will enter the urethra when the micturition reflex is active. So when you're like, oh my God, if I don't get to the bathroom now, I'm gonna pee myself, you've got urine in your urethra. You've just got you've got a hold of that external urinary sphincter that's preventing it from being voided out of the body. Yeah.
I know this is a jump question or not, but whatever individuals or like women have UTIs, why is it that the kidneys like are so much?
So here's the problem. It's not that they have UTIs, it's that they end up with kidney infections because all of that is connected, right? So what happens is that women don't get their UTIs treated. And so that bacteria works its way up the ureter to the kidney and causes a kidney infection. Yeah.
So kidney stones.
Kidney stones are a result of precipitation of material in the nephron not being voided properly. Yeah. But you can get bladder stones too. Yeah. My personal favorite is the gallbladder stones. He's so cute. I make these for you. He's so cute. He's my favorite. No, but alcohol is toxic. And your body is trying to get rid of as much of that as possible. So it's going, and your parasympathetic nervous system is going to get kicked up, right? Because you're drinking, you're depressing all of that, right? You're not going to be stressed. Your sympathetic nervous system isn't going to be active. So the peristaltic waves are going to happen more frequently, which is going to fill your bladder more rapidly. And you're taking in a lot of fluid. right? When you're drinking, particularly if you're drinking heavily, you're taking in a lot of fluid, right? And the body's just going to keep moving it into the bladder. So yeah, alcohol doesn't increase the micturition reflex, but it can help increase peristalsis, which will increase the speed at which we fill the bladder, which will then increase the micturition reflex. Okay. You guys with me? All right. I need you guys to focus. We got to get through as much as we can today because you guys are about 6 or 7 slides behind. So we are talking about 3 processes. 4 technically, if you count excretion, we'll get there. We have filtration, we have tubular reabsorption, and we have tubular secretion. Now, I want you to lock something into your brain right now, okay? Tubular reabsorption means that I am moving materials from the tube into the blood. Okay? Tubular reabsorption means I'm reabsorbing things from the tube into the body. I'm keeping them. Okay? Tubular secretion means I am secreting from the blood into the tubule. Anything that is in the tubule at the end of this process is going to get voided with the urine. So if it's something I want to keep, I need to reabsorb it. If it's something I need to get rid of, I need to secrete it or filter it. Does that make sense? I can. If it's something that I want to keep, I need to reabsorb it. I need to take it out of the tube and put it back in the blood. Right? If it's something that I want to get rid of, then I'm either going to get rid of it through filtration or through secretion. Okay? Yes. In this process, filtration only happens once. We get one shot at filtering. After that, if we need to get something out of the blood, the only thing we can do is secretion. Okay? Tubular reabsorption and tubular secretion happen multiple times through this process. Okay, and we're going to talk about where everything happens and what happens with those things in a minute. I want you to keep this visual in your mind. Okay, these capillaries wrapped around these tubules. Okay, because we are going to be moving things back and forth between them. Right? And if you keep this visual in your head, it will be easier for you to understand what's going on. Okay? Yes.
The capillaries, do they stem from that glomerular?
So it's a separate capillary network, right? The efferent arteriole leaves the capillary and it's a whole nother arteriole, right? So it's no longer a part of the capillary. That arteriole ends at the next capillary bed. That's why it's a portal system. Okay? Because I have one capillary bed attached to another capillary bed. Okay? They have very different functions. They have very different structures, right? So the capillaries that are in the glomerulus are fenestrated and they have those podocytes wrapped around them to help with filtration, right? The capillaries that are in the peritubular capillaries, they are structured differently. They don't have as big a fenestrae and they don't have those podocytes wrapped around them. They're different kinds of capillaries because they have a different job. Okay. All right. So this first set of things on this PowerPoint is mostly just definitions. Okay. You don't need to worry about the numbers. I've given you numbers here to help you sort of get an idea of these things, but I'm not going to ask you what the average renal fraction is or how much plasma flow happens per minute. I'm not going to ask you that. You should know the definitions of these things. I do want you to pay close attention to glomerular filtration rate because that tells you how much filtrate is being produced per minute which is a measure of how efficient your kidneys are. Okay. Average urine production is somewhere around 1 to 2 liters per day. That number you should know. Okay. Most of what gets filtered, so go back and pay attention to that, right? Glomerular filtration rate. You're filtering 180 liters of filter per day. You are emptying out of your bladder 1 to 2 liters per day. It's getting reabsorbed. It's getting reabsorbed. We're going to talk about that. Okay. So it's a big difference. Your kidneys are very busy all day long, all night long, pretty much all the time. They never get a break. Give them some water. So we've talked about the filtration membrane. I'm not going to spend a lot of time here. We've already talked about it. The filtration membrane is designed to prevent what 2 things from leaving the blood? Proteins and red blood cells, large proteins and red blood cells. There are some little tiny itty bitty little proteins and protein fragments, microproteins, that will get filtered. But large proteins and red blood cells should not be in the urine. If they are in the urine, that is an indication that there is a problem in the nephron. Okay. Okay. We have 3 numbers here. We have glomerular capillary pressure, and I'm gonna give you some abbreviations of these that will hopefully help you remember these. We have glomerular capillary pressure, which we can also call our capillary hydrostatic pressure. Does that sound familiar? Yeah. We have capsular pressure, which we're going to call our interstitial hydrostatic pressure. We have colloid osmotic pressure, which we're going to call our blood colloid osmotic pressure. What am I missing? Aren't there supposed to be 4 numbers here? Well, net filtration is how I calculate. Interstitial colloid osmotic pressure, the osmotic pressure of the solution surrounding. It's not here because it's not relevant. In the Bowman's capsule, in the renal corpuscle, interstitial colloid osmotic pressure is usually equal to 0. Okay. Now, I want to make sure we all understand what's happening here. Okay. Capillary hydrostatic pressure, glomerular capillary pressure, is the pressure exerted by what? Where? So, what's exerting the pressure? What kind of pressure is this? It's hydrostatic pressure, right? So hydrostatic pressure is exerted by fluid. And where is the fluid? Inside of the capillaries, inside of the glomerular capillaries, right? Okay. So this pressure is happening inside. Oh, that's almost the same color. Is happening inside of the capillary, right? This is the fluid, the blood and the plasma traveling through the capillary, exerting pressure on the wall. Okay. What about interstitial hydrostatic pressure? Where is that? This is out here in the capsule. Yes, in the Bowman's capsule, in that capsular space. Okay. So I've got hydrostatic pressure exerting pressure on the capillary walls from the outside. That's my interstitial hydrostatic pressure. I have hydrostatic pressure from fluid inside of the capillary, exerting pressure on the inside, okay? This is the one that's often hard for students to get because of the way that it's designed in this figure. Where is this happening? It's the other way. Yes. Blood colloid osmotic pressure is caused by the large proteins, primarily, that are inside of the capillaries, right? So remember that hydrostatic pressure, so if I've got a blood vessel, hydrostatic pressure is going to exert pressure this way, right? This is hydrostatic. Osmotic pressure is going to actually exert pressure in the opposite direction. It's going to pull rather than push. Okay? So those proteins on the inside are trying to pull fluid in. You with me? You with me? Okay, so let's look at this. What information can you get about these things just by looking at this figure? Without looking at the numbers. The numbers don't, just if I took all the numbers away, if I took everything off, if I took all of the numbers off, what could you tell about this figure? What are you paying attention to? The arrows. What are the arrows telling you? Okay, so it's telling me which direction the pressure is trying to move fluid. What else does it tell me? How much effect that pressure has, right? We want to make sure that in our nephron, our glomerular capillary pressure is always bigger than the combination of these two, right? Because they're going in opposite directions. And we want to make sure that we are filtering the blood. And in order to filter the blood, I need to move stuff from inside of the blood into the Bowman's capsule, right? I need a positive net filtration pressure, okay? Right? 50 minus 30 plus 10 gives me a positive net filtration pressure, which tells me that water fluid is going to leave the capillary. Yes, it always has to be positive. If it's not positive, then we're not filtering, right? I can't get anything out of the capillary. I'm going to be pulling fluid into the capillary, which is contrary to what I want to do here, right? Does that make sense? Okay. And just in case you haven't noticed it, this is the same text as this. It's exactly the same. I just put it in two places. Don't ask me why. I don't know. Did it a long time ago. Okay, so most of what's on this slide we've already talked about. Okay, we've talked about what filtration pressure is. We've talked about the different kinds of filtration pressure. We have talked about the fact that colloid osmotic pressure in the Bowman's capsule is normally close to 0. When proteins that are in the red blood cell get pulled into the Bowman's capsule where they're not supposed to be, that is going to cause a change in this number. It's going to make this number go up. And that is a problem because we're now moving away from our positive net filtration pressure. We call that glomerular nephritis. Okay. Now, because we have to keep the pressure in the capillary high, there are multiple mechanisms that we use to control that. The first thing that we have to have is we have to have low resistance to blood flow in the afferent arteriole. So first of all, where is the afferent arteriole? It's coming into the glomerulus. It's bringing blood into the glomerulus, okay? How do I lower the resistance to blood flow in a vessel? I'm going to make it bigger. I'm going to vasodilate, right? That afferent arteriole is bigger than the efferent arteriole. Remember that? Yeah. And it's bigger because we need lower resistance to blood flow. Now, I want you to think about this for a minute. Nobody answer, just think. Why does increasing the volume of the space, why does making the afferent arteriole bigger increase pressure in the capillary bed? Because I have more volume of blood. Yes. Yes. So remember, we have our tube, right? And that tube narrows, right? So if I have lots of blood coming in and I have a little bit of blood coming out, I'm going to back up in here, right? That's going to increase the pressure. Everybody's trying to force their way out. Okay. The more blood comes in and the tighter the control I have at the other end, the more pressure I'm going to create. Okay. Now, I can't go from here to here, right? It's got to be a gradual decrease. So I need a relatively low resistance to blood flow in the capillaries too. Because if I don't have a low resistance to blood flow in the capillaries, what's going to happen to my capillaries? They're going to explode. Okay, we don't want to blow up the capillaries. We just want to raise the pressure enough that we can force the fluid out. Capillary damage in the nephrons, it happens, and we're going to talk about why in a minute. It is not hugely common, but it is common, particularly in people with high blood pressure. Think about that a minute. The third piece of this is that I need high resistance to blood flow in the efferent arteriole. That's that little guy at the end, right? We've got to make him smaller so that we have lots of blood coming in and less blood coming out. That's going to raise the pressure. Okay. Now I'm going to ask you a question. Yes. After I answer one.
The blood pressure is higher in the afferent than the efferent?
No. It's the other way around. Yes. So let me ask you this. Which pressure is higher? Systemic blood pressure or glomerular blood pressure? So I've got a vote for glomerular, I've got a vote for systemic, which means you each got a 50-50 shot of getting right. What do you think? Where is pressure going to be higher, out in the body or in the nephron, in the glomerulus? Pressure increases when I go into the glomerulus, right? I'm increasing pressure in the glomerulus, which means I'm taking whatever pressure exists in the body, I'm taking systemic pressure and I'm increasing it slightly in the glomerulus in order to filter. Right? Does that make sense? So what happens if systemic blood pressure is high? Then glomerular pressure goes even higher, and that is where we run into the risk of damaging the capillaries. If we can't control that pressure enough, if blood pressure in the systemic blood pressure is constantly too high, then we don't have the ability to regulate the pressure in the glomerulus enough to protect those capillaries. So people with high blood pressure run the risk of kidney damage more so than people with normal blood pressure. Does that make sense? Yeah. Okay. Okay. two different mechanisms that we can, well, really four, but two different major groupings of ways that we can regulate glomerular filtration rate. Now, in order to regulate filtration, we have to know what we need to filter, right? We need pressure to filter, yes? Okay. And we need to be able to vasoconstrict or vasodilate in order to adjust how much blood flow is coming in, right? So we have two groups here. We have intrinsic and we have extrinsic. Now, here's what you need to get in your head, okay? Intrinsic or auto-regulation happens when the kidneys detect an issue and the kidneys self-correct. There is no influence of anything outside of the kidney in auto or intrinsic regulation. Okay, so we have two mechanisms here where this works. And both of these mechanisms will affect how much we constrict or relax the afferent arteriole. Okay. If my blood pressure is too high, if I need to lower the pressure in the glomerulus, what is one of the ways that I can do that? I want to lower the pressure in the glomerulus. Yes, increase resistance where? More specifically. Yes. I want to increase resistance in the afferent arteriole. I want to slow down the amount of blood coming in, right? Remember, we generated that pressure by allowing extra blood to come into that capillary bed. So if I vasoconstrict the afferent arteriole, I reduce the amount of blood that's coming in, which lowers the amount of blood in the capillary bed, and I don't have as much pressure building up. Okay, so the kidney's going to detect this issue in one of two ways. Okay, and I want you to think back and remember back to the macula densa and the juxtaglomerular cells that we talked about, right? The juxtaglomerular apparatus, because they're going to come into play here. So the first thing that we need to talk about is the myogenic mechanism. And that happens when the afferent arterioles detect an increase in systemic blood pressure. Okay? We have an increase in systemic blood pressure. The afferent arterioles are going to vasoconstrict. When the afferent arterioles vasoconstrict, pressure in the glomerulus is maintained at the appropriate level, right? We are trying to keep a relatively constant filtration rate, right? We don't want our filtration rate going up and down and up and down. We want to maintain a constant rate. In order to do that, we have to maintain a relatively constant pressure. We vasoconstrict the afferent arteriole to maintain that constant pressure, okay? The next way that your kidneys detect and respond to this is not actually by looking at the pressure in the blood, but by looking at the speed with which filtrate is traveling through the tubule. Okay, so is filtrate going to be faster or slower if blood pressure is too high? Faster, because higher blood pressure is going to cause more filtrate. Right? We're going to filter more than we would normally. That's going to increase the speed at which that filtrate is flowing through those tubules. Because remember, it's hydrostatic pressure that's driving that movement. Okay? That speed is detected by the macula densa. You guys remember when we looked at that picture and there were those funny looking cells in the distal convoluted tubule, right? Those are the macula densa, and they detect the rate of filtrate as it flows past them. When they detect a high rate of flow, they actually send a signal to the juxtaglomerular cells, which will then cause the afferent arteriole to vasoconstrict, which will decrease the amount of flow coming into, the amount of blood coming into the glomerulus, which will lower the pressure, which will reduce the filtrate speed. Does that make sense? Yeah? No? Maybe? We getting there? We doing okay? Who's lost? Who needs me to back up? Who's stuck somewhere? We doing okay? All right. Extrinsic mechanisms. These are actually much easier, mostly. So extrinsic mechanisms basically means that something other than the kidney is having an effect on the kidney. Okay? This is only going to happen during really severe situations. Hemorrhage, where you're losing blood, or severe dehydration, okay? Where your body just is starting to lose blood pressure, okay? The sympathetic nervous system is the first mechanism that we use for external or extrinsic control. And we're going to use that sympathetic nervous system to constrict the small arteries and vessels. We're going to make everything smaller because we've either lost a lot of water fluid or we've lost a lot of blood volume. And we need, in order to make increased pressure, we need to make the tube smaller. All right. When we make those tubes smaller, we're going to actually decrease the amount of blood that's going to flow into the kidney. Because if I have a limited supply of blood, I need to keep as much of it circulating through my brain as possible. And to hell with my kidney. Okay? Which means I'm going to have less filtrate formation. All of that is going to slow down. The other mechanism we're going to use to increase blood pressure when blood pressure drops is renin. Do we remember renin? Okay? So here's the thing about renin. And I'm going to actually skip forward a few slides so you can see what I'm talking about. It's way up there. It is. So I told you that extrinsic mechanisms are related to things that are outside of the kidney affecting the kidney. Okay. This one causes a little bit of trouble because the first step in this is the kidney producing renin, right? So the kidney produces renin, but renin is not actually going to have a direct effect here. Renin is going to meet up in the blood with angiotensinogen, which is produced by the liver, which is going to then get converted into angiotensin 1. That blood is going to run through the lung and encounter angiotensin converting enzyme, which is going to turn it into angiotensin 2. Angiotensin 2 is a vasoconstrictor. So angiotensin 2, which is produced outside of the kidney, is going to cause vasoconstriction, which is going to reduce the size of those vessels, which is going to raise the blood pressure. Does that make sense? Is this all starting to come together? Yes, no, maybe a little. Okay, we'll talk about this again later. I'm going back. Woo. Woo-hoo. Okay, so those are the intrinsic and the extrinsic. You need to know which ones are intrinsic, you need to know which ones are extrinsic, and you need to know the basic actions of each. Okay?